in UK very frequently, which is Ehlers-Danlos syndrome, and it is just a hand pain in middle-aged girl. Okay, and when you go through all the pain, all the details of the pain, if you didn't ask about the increased laxity, okay, you'll not get any answer, and you will be lost in the 6 minutes of station 5. And this was the case of station 5 and came in Whip's Cross. Okay, so you need to ask the question clearly: do you have a laxity? Okay, an increased laxity in your joints. Okay, then what is the opposite for the laxity is a stiffness. So you will ask about stiffness, and here you may get the answer of yes and the answer of no. If there is a stiffness, okay, if there is a stiffness, I'm talking about inflammatory. And remember, when it is an inflammatory pain, okay, it will be increased during rest. It will be more improved during working. So if you get two answers, I have a stiffness and the pain a little bit improved while I'm doing activities. So this will go with the inflammatory nature of the pain. And once you go to the right side of the algorithm and you found that the stiffness, okay, and the criteria of the pain during the activity it's improving, you need to ask one important question, which is about the duration of the stiffness. And here the duration, because I found some candidates think that you'll get a very sharp answer from the candidate, from the surrogate. Sometimes you'll not get a clear answer. Sometimes you'll find the answer of, you ask him less than 1 hour, he will say, I'm not sure, doctor, because sometimes this is not a part of his scenario, okay? And the surrogate just answer depending on his scenario, okay? So you'll ask him, if it's less than 1 hour, you can ask him, is it in the beginning of your day? For how long does that extend? Let me give you an example. Does it extend the whole morning with you? No, doctor. Once I wake up, okay, and then after a while, after my breakfast and start moving, I'm fine. Okay, this is for less than 1 hour. Then if you ask the patient with a seropositive, and he told you, asking him about the duration of stiffness, he'll tell you, yes, doctor, it takes the whole morning. Sometimes it just relieves after 12 p.m. Okay, so again, don't expect to find a white and black in the exam, but at least you need to be organized, and every question you are asking, you are trying to hunt something in the case. Okay. Then here I have the approach for if it's less than 1 hour, inflammatory in nature, okay, and associated with back pain. So I will expect to find the ankylosing spondylitis. Okay, I can expect the presence of psoriatic arthropathy. So you can write that because it's not written in the algorithm. The A for ankylosis, the P for psoriatic arthropathy. Okay, but the circle, all the blue circle I'm using in all my algorithms when I use it, it is for the seronegative conditions. Okay, seronegative arthropathies. So when there's a back pain with the shoulder pain, I would expect, or the neck pain with the shoulder pain, I will, and that pain improve with movement, and the stiffness is less than 1 hour, will take a small parts of my morning. So I would expect the presence of ankylosis. And to ask about ankylosis, as you know, we'll ask the 5 A's of ankylosis. Okay, we'll ask about anterior uveitis, we'll ask about any redness of the eye, any pain in the eye, any excessive tearing of the eyes. I will ask about heart racing, shortness of breath because of aortic regurg and because of the apical lung fibrosis. I will ask about frothy urines and pins and needles for the amyloidosis. And I will ask about the Achilles tendonitis, the pain in the ankle because of the Achilles tendonitis. Okay, then I will go to that. P for psoriatic arthropathy, so I will ask about any skin rash, and I will ask about nail changes. And if there is a skin rash, there is an approach for that. Okay, then as usual, as you know, for the psoriasis, there should be affection of the nails. Then for the B, it is a basic disease. So how to ask about basic disease? We have 4 questions. We are asking about soreness in the mouth, any soreness in the mouth or private areas, any history of any blood clots, any other joints pain. Okay, so we have the soreness in the mouth and genital area, and history of blood clots and the joints pain. Then for the R, reactive arthritis, and as I said before, it's like Reiter syndrome. When we ask can't P, can't C, can't climb the tree. So can't C, there is an eye problem. Can't P, there is urination problem. Can't climb the tree, there is a joint problem. And here you will find, remember, this is an important point because again, all the candidates have a problem with it. You will go and ask about the pain, the infection, and you'll say in a recent infection, and it shouldn't be recent infection, and it shouldn't be that much close to your symptoms. It should be related to the symptoms. I mean, maybe this patient has symptoms since 9 months. So the question should be, did you notice that these symptoms started after a specific or certain infection that you suffered of? And this will make a big difference. When you found this, the surrogate will have this answer. He will have the answer, yes, before 3 weeks, I have a severe loss motion, or I have a burning migration, and it was started on burning urine works, and they have at that time antibiotics. Okay, then or you will find even chest infections. Okay, so the question should be the relation of the symptoms with the history of infection. And then enteropathy. Okay, there is enteric arthropathy or enteropathy, which is association with the malabsorption. Like when you ask about inflammatory bowel disease, so you need to ask about loose motion, about any blood coming with the stool, about any weight loss, about in general with the loose motion that is difficult to flush. Okay, any history of tummy surgeries for the Crohn's disease. So you will ask this question very fast, and I know that you feel now we will spend a lot of time to ask this question, but actually no, because once you ask about the laxity, no, so you are done. Then you'll ask about what increase and decrease. Then you will find the stiffness. Then you will check if it is improving with that, with the stiffness, the duration of the stiffness. When we are going to this circle, we'll catch one of these, and this could be our diagnosis, and we are done. Okay. Then what if we found that no, the stiffness extends for a longer time? Okay. Here you remember the pink or the red color circle. Okay, which is the seropositive group of diseases that can cause these symptoms. The first is R for rheumatoid arthritis. Okay, so to ask about rheumatoid arthritis, you ask about the joints of the hand. You ask about swelling, and you ask about the symmetry, as we said. And for all the seropositive, you need to ask about the shortness of breath, and you need to ask about frothy urines. Okay, so the shortness of breath and awareness of heartbeat, and the problem in the frothy urine is a question that should be included with all the seropositive, because as you know, rheumatoid arthritis causes amyloidosis and causes renal affection, and there is pulmonary affection of the lung, and there is affecting the heart, and systemic lupus as well, and systemic sclerosis as well, so and mixed connective tissue as well. So all the other diseases can affect the lung, can affect the heart, and can affect the kidneys. So you should ask these 3 questions whenever you are in the area of let me put the charger. In the area of the seropositive. Okay, so here I will ask about any hand joints pain, and if the answer is yes, does it affect the joints in the tip of your fingers? Because as you know, the rheumatoid arthritis will spare the distal interphalangeal joints. Okay, then you ask about the frothy urine and shortness of breath, as I said. Then you will go and ask about the S, which is the systemic lupus. And how to ask about systemic lupus? You'll ask about any rash affecting the face or areas exposed to the sun. Okay, you'll ask about mouth sores. You'll ask about frothy urine. This is what we call screening question. I mean, this is not all the questions for the condition, but whenever you found yes or yes, you should proceed to confirm your diagnosis. So you'll ask your screening question for systemic lupus. So then you will go to the second S, which is the Sjogren syndrome, and you ask about dry mouth and dry eyes. Then you will go to the third S, which is the systemic sclerosis. And here you need to ask about tight skin, difficulty in swallowing. Again, this is a screening question. You can add for all the circle, change of the color of the tip of the fingers with the cold weather. For the Raynaud's, because the Raynaud's could be associated with any of all the seropositive conditions. Okay, then you will go to the DMP, which is dermatomyositis and polymyositis, and here you will ask about the muscle tenderness, and you'll ask about rash around the eye for the heliotrope rash. Okay, and there is a region or projections or lumps and bumps in the fingers for the gastronodules for the dermatomyositis, and remember the association with cancer. Okay, then we will go to just a second. Then we will go to the antiphospholipid syndrome, and here we will ask the same question of systemic lupus and add to that history of recurrent blood clot and a female of recurrent miscarriage. Okay, remember here when you put systemic lupus, I want you to add for that with the systemic lupus what is called DIL, the drug-induced drug-induced lupus erythematosus. Okay, so add with the systemic sclerosis the DIL, drug-induced SE, the drug-induced lupus LE. Okay. So here's how you ask about this circle, and if they are hiding any of these as a cause of the joint pain, you will catch that. But the important part, which is unique, again, until now you can implement the same for the knee pains. Okay, the inflammatory knee pains, you can implement that on the inflammatory hand pains. You will catch the diagnosis of the psoriasis, you will catch the rheumatoid, systemic sclerosis by going through this side of the algorithm. Okay, then here is what's important, which is the polymyalgia rheumatica. And for the polymyalgia rheumatica here, this is unique for our shoulder pain case. Okay, and here I wrote for you what is the criteria for the polymyalgia. And the polymyalgia, again, it will be inflammatory nature of the pain, although the pain is more through the day, but it is more in the morning as well. Okay, and there is a stiffness, and it is more than 1 hour. The patient will tell you usually it is more than 1 hour. So if you want to put it somewhere in this algorithm, I would prefer to put it under the 1 hour, more than 1 hour. As you like. There is only stiffness, you can use the polymyalgia anywhere, but it is part of the inflammatory affection of the joints. Okay, what you want to know about polymyalgia, again, for the cases, I don't want you to know more details. Don't ask very detailed questions. You need to reach the diagnosis and have a management plan. You don't have enough time for that. Okay, so you should have a question that you will ask, you will catch the diagnosis, and we are done. Then here in the polymyalgia, I want you to know that there is a high ESR, there is a shoulder stiffness. Okay, there is a symptom, there could be in 40% of cases, there is a symptom of temporal arthritis, signs and symptoms, which include, or the genital arthritis, which include the blurring or sudden loss of vision, tenderness over feeling the temporal artery, there is jocularcation, and there is scalp pain. So you need to ask this question with any case of polymyalgia, and I will show you how to ask the question of polymyalgia in the next slide. Then there could be a fever, there could be a weight loss, and that's why this can, and there is a loss of appetite, and this can merge with the cancer. So usually you can mix between polymyalgia and cancer and polymyositis and dermatomyositis because they are associated with cancers. And in cases they like to do that. They like to confuse you between these three, giving you some symptoms, looks like cancer, you are confused, and you catch the cancer, this is wrong. You catch polymyositis or dermatomyositis without clear findings. So it is polymyalgia rheumatica, but you didn't notice that. So, and there is weight loss, and this is very important. It is not weakness, although you can't examine the weakness perfectly in this case because of the pain if it's in station 5. But usually this patient may have pain, may have weakness. They can develop recent weakness. In the chat box, give me the answers why this patient can get a weakness later on. Write that in the chat box, please. Yes, great. Perfect. No, Dr. Muhammad Ali, it is not this use more than it is effect of steroids. These patients, the main treatment for these patients are steroids. So here you need to consider the steroids as the cause of the recent weakness. So if the patient have all these symptoms, and then with time you found that there is a weakness, okay, so it could be the proximal weakness related to the usage of steroids. Okay. So this is for this side of our algorithm, but here I want to add something. Just remember it. When we reach it, there is other condition that can be associated with stiffness and pain, but it will be confusing because the criteria could be a mix between the inflammatory and mechanical, and we will go through that and I'll tell you how to ask that in the exam. I see that many of the doctors who attended our course before attending our lecture today. So doctors, there is some modification here I bought in this case. Okay, then I just added here, and I was planning to send you. You will receive all the doctors who attended the course of November and December and January. You will receive some recent because I have a slide for eczema and I have a new slide for these modifications. I modified this algorithm. Okay, so you receive that. Your emails that listed in my email. Okay, so the stiffness here, if we find no stiffness, we are talking about the mechanical pain. Okay, and for the mechanical pain, as usual, we need to know, is it a gradual or sudden pain? Okay, so now please doctors, try to forget about the right side, try to stop feeling that it's a very long approach because we are done once we found the answers no and no. So we are here on the green side, which is the mechanical. Okay, and in the stiffness in the mechanical, I'm going to ask whether it is sudden or gradual, and if it's sudden, I want to exclude trauma. And why the approach is important, doctor? Because in this case, for example, Dr. Rita, forget to ask about trauma. Trauma is a very common cause. If the patient have a neck trauma, if the patient went to the gym and he started to develop this shoulder pain, maybe he made a compression of the cervical vertebra, for example. Maybe if it is one shoulder, there is direct trauma happened to the shoulder. So the examiner want to hear you asking this question, even if this is not the case. That's why if you can memorize this algorithm during the exam, this will make you look very perfect in the case. Okay, so here for the T, you'll ask trauma. Okay, and is there any trauma happened to your neck or your shoulders? Then for the S, here I'm asking about the septic. So for the septic arthritis, which will be acute, there should be hotness, there should be redness, there should be a history of fever, high fever. Okay, there could be a history of incomplete antibiotic treatment for an infection. Okay, I want you to add to this S. Okay, add to this S incomplete treatment of infection, and add here recent procedures because of there is one case came shoulder pain, and for unknown reason they want you to catch infective endocarditis. There were fever when you ask their heart racing, and they have a history of recent procedure, and the patient have a history, I think, have a history of previous cardiac valve replacement or something put him at risk of infective endocarditis or previous attack of infective endocarditis. So they expect this. It was in UK, and they expect the candidate to catch the diagnosis of infective endocarditis, although it is weird, but add it to the S, septic arthritis. I want you to add here recent or previous recent procedures, and add infective endocarditis to the septic arthritis, and add a non-completed treatment or antibiotic treatment for any recent infection, because some patients, as you know, they can have disseminated infection when they don't continue their treatment. And we have one example of this case Okay. Then we'll go to the C, which is crystals. And here I want you to write this because the crystals here, I mean the gout and the pseudo gouts. Okay. For the gout and pseudo gout. Again, remember, this will be your approach as well. Till now, you can approach all this algorithm without the polymyalgia for the knee pain. Okay. So in the knee pain, also shoulder pain, you will go through that. For the gout and the pseudo gout, you have two lines. There could be uric acid, risk factors like psoriasis. So here, remember, never miss asking about psoriasis. I mean skin rash and nail changes in any cases with gout. And you can ask about the specific pain. Is it in the base of your the big two? This is for the gout. Okay, although it can affect any joint, but usually the pseudo gout affecting the larger joints, like the shoulder and the knee. So you ask in uric acid about psoriasis. Write that down, please. You ask about diuretics. Diuretics increase the uric acids. Then you ask about the alcohol and the nature of the food. Some people just eating protein and red meat, a lot of proteins and red meats. So ask about alcohol and the foods. Lymphoma or in lymphoproliferative conditions or blood cancers can cause gout. So you ask about bundle one. As we said before, I don't know if you are aware of bundle one, but you ask about loss of weight, about anorexia, loss of appetite, about lumps and bumps anywhere in the body, bleeding from any orifice of the body. So you're asking about cancers in general. Then you need to ask about the family history because the family history of gout is a component of what is called the Leishman syndrome. And usually it is not a case because there is a fifth mental retardation and gout. So just ask about the family history of same condition. So this is your approach for the crystals. This is your questions for the crystals because it can be only the case is patient on diuretics with severe leg pain or foot pain, and you'll find it is gout only because of that and some renal colics because the patient is on diuretics, and this is what's hidden in the exam. So if you just go through this approach of the joint pain, if it is a foot pain, you will go and in this point you will catch that he is in diuretics and we are done. If you just go through a bizarre approach, you may lose the case. Then the stool gout, you will ask about the cause of increasing calcium, and here I'm talking about I need to ask about TB, any cough, coughing out of blood, any exposure to chesty patient, weight loss, okay, night sweat, sarcoidosis. I will ask as a cause of hypercalcemia and pseudo gout, and as usual, sarcoidosis will ask about shortness of breath, pain in the leg, and rashes. And some rashes in the nose as well. There is a rash of erythema nodosum on the leg, painful rash, and there is locus pernio on the nose. Then hemochromatosis. Hemochromatosis as a cause of hypercalcemia. And here you ask about diabetes, any history of elevated blood sugar or uncontrolled blood sugar if the patient non-diabetic. Did you notice any skin pigmentation, yellowish color of your sclera, and any problem with your intimate relation? This is for the hemochromatosis. Then thiazide diuretics. Thiazide diuretics, as I said before, thiazide in Arabic sayazid al-calcium. So thiazide, yazid al-calcium. So the thiazide is a cause of hypercalcemia. And you should advise the patient about controlling the thiazide or change his diuretics if he has a hypercalcemia. Then Min syndrome. And in Min syndrome, which is a very important topic we discuss in details in our course, you will ask about the pituitary acromegaly, any change in the size of the ring and shoes, blurring of vision or problem with the side vision, phychromocytoma. There is a flushing, okay, hand sweats and handshakes, tummy pain. You will ask about vision problem, okay. Then the last H, this in TSCH, you will ask about the hemorrhagic arthritis, and this can happen in any joint. And here you need to ask 4 questions that usually we are asking for the bleeding. For all the doctors who attended with me in the course or our free lectures, we're asking the 4 questions of hemorrhage. We don't keep repeating them, but the question is, do you have any previous history of bleeding? Do you have any other bleeding from any other orifice? I mean, if you have bleeding in the knee, there could be bleeding from the nose. So any bleeding from any other orifice of the body. Then any history, family history of bleeding, patient with hemophilia, patient with von Willebrand. Then the 4th question is any blood thinning medications, any blood thinning medications. Okay. So these are the questions of the hemorrhage. So the TSCH working this algorithm without the polymyalgia can work with the knee pain, can work with part of the hand pain. The hand pain includes a lot of other things, and it can work with the shoulder pain. But here we will add 2 things. I'm sorry, I get a lot of messages now in the chat and on the WhatsApp, but I can't answer this because I can answer the question while the discussion. Okay. So I will go here through these 2 parts, the A, okay, and the F. The A refer to what? Avascular necrosis. Avascular necrosis. And the F refer to what? Frozen shoulder. If you want to use another name to make it A and A, it will be adhesive capsulitis, if you want, as you like. And here is what I told the doctor that we changed that the F, the frozen shoulders. We noticed that one case that came and was associated with stiffness, and I found that it is related to the stiffness. Okay, there will be a stiffness with the case of the frozen shoulder. Okay, so you may find it looks like mechanical pain. It looks like mechanical pain criteria, but there is a stiffness, so it could be a frozen shoulder. So you should ask about the risk factors in the shoulder pain for the frozen shoulder and for the avascular necrosis. And here there is TDRS, which is Tedros. Okay, Tedros here. For the causes of just the most common causes of the avascular necrosis, you will add to this Tedros PhD. I mean, she studied PhD. So Tadros PhD, and I will tell you what that refers to. And there, the F for frozen shoulder refer to DT Shep. DT Shep. And I want you now to write this letter refer to what? Okay, this Tadros refers to the T as for the vascular necrosis refer to trauma and transplantation. Trauma and transplantation. They found that 15% of the patient post-transplantation will develop a vascular necrosis. And trauma can cause the vascular necrosis, and you can find that in the patient with Charcot joints because they have recurrent painless trauma. Then the D for diabetes. The D for diabetes. Then the R for radiations. And the S for systemic lupus and sickle cell anemia. Sickle cell anemia will go and block the blood supply to the joints, okay, by the vaso-occlusive crisis, and then you will get a vascular necrosis. Okay, then the PhD, I want you to add here PhD. So Tadros PhD means someone studying PhD. The P refers to pregnancy and pancreatitis, and then the H for hemo, dialysis and HIV, and the D for drugs like steroids and alcohol. Steroids and alcohol. Okay, so these are the causes for the avascular necrosis. Okay, how to reach this point as well? Again, you will go through your question, and you found nothing going with this, nothing going with that, and you found it's going like a mechanical pain, and you found this pain is it could be, because it's shoulder pain, it could be a frozen shoulder, and it could be, and here there's a correction, because I said before that we can't go the frozen shoulder with sudden, but actually the frozen shoulder could be sudden, but it is gradual progressive. So there is a stages of the frozen stiffness, a frozen shoulder. I don't want you to know that in details, but actually the phases of frozen shoulder include initial, which is the initial painful, and this is what the patient will come to you with. He will come with severe pain, initial painful, and this some increase at night associated with stiffness, and this may last for 9 months. So the patient may still for 9 months have this pain, and this is a frozen shoulder. Okay, then you will go to that next phase will be the second phase, which is the stiffness with severe loss of shoulder motions, and then you will find the pain is improved, and then within 2 years you will find the recovery phase. So it looks, I want you to have an idea about that because this case came as well in the exam in the last year, okay, and it was a frozen shoulder. So it shouldn't be, the patient will come with acute pain, yes, but you will find a chronic history. So don't let that confuse you to say, no, the frozen shoulder should be very acute. No, the patient may have it's gradual, but sometimes it started by the painful attack, and sometimes it is recurrent. And they found that the patient with diabetes type 1, okay, 79% of person will develop frozen shoulder over their life. So this is a very high percentage, okay? Okay, so for the frozen shoulder, as I said, what is the causes of the frozen shoulder? Okay, it could be diabetes, so you add here diabetes for frozen shoulder. You will add trauma, you will add stroke, hypothyroidism and hyperthyroidism, and immobilization. So immobilization will be a cause of prolonged disuse or not using. Okay, and then the P Parkinsonism. Then the P Parkinsonism. So again, for the avascular necrosis, I said TDRS, PhD, Tadros, PhD, trauma, transplantation, diabetes, radiation, SLE, and sickle cell. Then PhD referred to pancreatitis and pregnancy, hemodialysis and HIV, and drugs like steroids and alcohol. For the frozen shoulder, we said the DT SHAP, okay, which is diabetes, trauma, stroke, hypothyroidism and hyperthyroidism, immobilization, and Parkinsonism. Okay, so that's what I want you to know about the frozen shoulder. And as usual, the treatment for these things, you should include the physiotherapy, you should include the pain killers. Okay. The pain in avascular necrosis, because I have this question, one doctor asked me how could be the avascular necrosis presented. You will find the pain, and if it is a head pain, it will be with weight bearing. Usually they bring the necrosis of the hip joint, so it will be weight bearing pain, or sometimes it is action pain or pain associated with action for the shoulder pain. 2/3 of this pain coming with rest, and 1/3 increase massively in the night, and sometimes it is asymptomatic. Okay, remember something, hyperlipidemia can cause both. Hyperlipidemia can cause avascular necrosis and frozen shoulder. So you will find that the statin could be a component of the treatment of both, or the prevention of both. Okay, so again, this is your approach for the differential diagnosis cases. Okay, for the shoulder pain. So doctor's asking me a question, I will answer the question after I am done of these cases. Okay, so again, this is my approach. Do you have a pain, any stiffness or laxity? If laxity, I'll go to this side. If a stiffness, I'll ask about if this pain increased during doing activities or decreased. Then I will go if there is stiffness, it is inflammatory, less than 1 hour. I will ask about the seronegative, more than 1 hour. I will ask about the seropositive, including the 3 general questions about the shortness please of 1, awareness of heartbeat and frothy urine. Then I'll ask about the polymyalgia rheumatica. And then if it is a mechanical, I'm going to ask about the silent causes, trauma and septic and crystals and hemorrhagic. Then I'm going to ask the gradual causes, which is overweight patient gain weight, so he has a shoulder pain and joints pain. Then overuse with a new job, which is not common. Osteoarthritis can come. When you exclude everything, it could be just overweight with osteoarthritis. Then you go to the A and F for the avascular necrosis, TDRS, PhD, and then for the F, frozen shoulder for the DT SHAP. Okay, this is your approach for the shoulder pain. If you just remove these and PMR, the polymyalgia rheumatica, you should remove. You can use this with the knee pain, and you can use as a part of the hand pain. Okay, some of this can be used with the back pain, but this, when we go through all the rheumatology, okay, in our course we discuss in details what is the difference. Okay, for the polymyalgia rheumatica, I want you to remember that there will be high ESR, there will be shoulder stiffness, bilateral, more than 1 hour. There could be a symptoms of temporal arthritis, so you should know that and ask about that and even examine that. Okay, then there could be a fever or not, there could be a weight loss or not. It is not weakness unless steroids is there. Okay. Then I know the problem with the candidate that that's what we make pressure on our course. That's how you go through the case. You get the diagnosis and you need to examine the patient. So you ask your questions and then you want to examine it in station 5. So the first thing you ask the examiner about, can I see the patient chart for the temperature? Then you will go to the shoulder because the pain in the shoulder. So you should start your examination by the shoulder. You will check any tenderness. You will ask the patient to resist his shoulder against your arms for proximal weakness. You will check if any tenderness and pain in the hip and the neck. Then you will go to the face, and at the face you need to palpate the temporal arteries. You will check for scalp tenderness because it's present in 50% of the cases with temporal arthritis. Okay, there could be thickening and reduced pulsation of the temporal artery. If this temporal associated with temporal arthritis in 40% of the cases, you need to examine the eye. You need to tell the examiner that I would like to examine the visual acuity and the visual field. He will tell you go ahead, so you need to examine it, or he will tell you no need, but you should mention that, and you should mention that you want to examine the fundus because you may find the fundus due to the vasculitis and the lack of blood due to the vasculitis and the temporal artery arthritis. There could be edema of the optic disc and cotton wool patches. Then you will tell the examiner that they want to do or carry a full CNS examination, neurological examination. So say that you need to do a full neurological examination. So you ask this question. This is station 5. You don't have time. You need to ask these questions. You need to check if these are high in the scenario. You need to examine these. I'm showing you in station 5 how to approach this case of polymyalgia. Then you will check the diagnosis. You will check elevated ESR and CRP. You will do a creatinine kinase, muscle biopsy, usually spared. Usually the muscle, although there is a muscle pain, the muscle will be spared. I want you to add EMG here to exclude the other causes. Okay. Then for the diagnosis, for the treatment. Okay. For the treatment, remember the main goal of the treatment to give steroids. The polymyalgia is very important because it can come in the communication. It's counseling. It's very common to come as a counseling. It came in Egypt and in UK the last day. Counseling the patient about the recent diagnosis of polymyalgia rheumatica. You should talk about everything in steroid treatment, the risk of steroids. Your main issue will be about the steroids and the temporal arthritis. Remember that. So the steroid, you will start immediately with prednisolone at the dose of 60 to 80 milligram oral if visual disturbance. Okay, you should start by high dose, 60 to 80. 40 mg will start if there is no affection of the vision. Then 40 mg per week in the first 1 to 4 weeks, then 30, then 20. You don't care about the dose, okay? But anyway, remember that the steroid, and there is a great response to the steroid in these cases. And some cases need the steroid all over their life, and some of them can stop it within months or within 2 years. Okay, this is what you want to know about polymyalgia. This is more than enough. Okay, and you can include the temporal arthritis and the genital arthritis in there. Okay, so now. First, I want to tell you that you need to be confronted with the structure of the history case. I mean, it's